My name is Dr. Abid Hussain from PEDS Unit 1. Today, our topic is regarding the development assessment. Although it's a very dry topic, and but we will try. I'll try my best that you capture many aspects of this topic. As you know that if you're living in Pakistan, you must be surrounded by many children of almost all age. We have a very strong social system here. If you're living in a flat, or if you see in a flat especially, you can see the children of each and every year and every month also sometime. So today we will discuss regarding the development assessment, how to assess the development. So there are two things. First of all, one is the growth and second is the development. One should be very clear between these two. Is a growth and there is development. The growth is usually said when there is a growth of any organ. Okay, it can be in size, it can be in quantitative. Usually, the parameters for the growth are usually weight, height, size, and shape of the body, like brain, hands, heart, liver. It is due to the cell divisions, and growth is usually of limited period. And growth can be measured in kg in different ways. As far as the development is concerned, it is a quantitative as well as a qualitative. In this, physical changes, cognitive, social, and emotional changes are also included. It is basically referred to the maturation of the CNS. It happens due to the motor and adjacent mental process and their interplay. Development takes place till death. It can be observed by mature behavior. So mature behavior is a development. So one should be very clear. Growth is different and development is different. Whenever the child is evaluated, it is evaluated for both growth and development. So weight, height, and all the things are not included in the development. The child can have a very good growth, but developmentally he may be lacking many things according to the age. So development is the individual level of functioning a child is capable of as a result of maturation of the central nervous system and psychological reactions. It is a quantitative and qualitative changes and acquisition of a variety of competencies for functioning optimally in the social setting. So whenever there is a growth of the CNS, you will find a change in the behavior, change in the physical parameters like walking, like sitting, like talking, like listening, and of course the eye movements. And socially, you must be recognizing that this is now mature child, this is immature child. If the child is around 1 year, he recognizes their parents, their relatives, and they maybe have some stranger anxiety at the age of 1 year. This is all developed through the brain. It comes with maturity. As far as if the child is less than 8 months, it will have no stranger's anxiety. He will go to everybody's hands with no issues. As compared, if the patient is more than 6 to 7 months till the age of 2 years, he will not like to go with the aliens people. So it is a milestone acquisition occur at the milestone acquisition occur at a specific rate and in orderly and sequential manner. It means that first the child, if I give example of motor milestones, the neck holding is first, sitting is after, and standing and walking like this. This is a sequence of motor development. So there is a same specific rate, and they are usually in an orderly manner. It is not that first the child starts walking and then starts neck holding. So there can be some abnormality also. Abnormality may be delay. The child may be delay. The child maybe have deviancy or maybe dissociation. We will discuss these things in next slides. So there are many in this lecture. There are many repetitions of same thing. Although sometimes it is very boring, but it is necessary so that you come up to what you are listening. Development is a continuous process from the conception to the maturity. And sequence of development is, I already said, it is same in all the children, but the rate may varies from different different categories to different. If you example, in this part of world, the speech development is far ahead than those who are born at Middle East, because there you don't have such a social gathering. You don't have many children in a house. When they meet, they started copying each other, and this is the way they speak earlier as compared to if the child is living in the Middle East or in other Western countries. He will be isolated in the flat, and there are not much social contacts as we have here. So they develop speech development much ahead than many other parts of the world. So development is intimately related to the maturation of the central nervous system and opportunity to practice. So development is in cephalocaudal direction. Certain primitive reflexes are lost before you get voluntary movements in the body. As in cases of children, the primitive reflexes, most of them, not all, they subside within 4 months. But after that, the voluntary movement starts in their body. So they started to get control of their body slowly. Generalization about development cannot be based on assessment of the skill in a single development domain. So there are different development domain also. We will discuss in the subsequent slides. There are different domains, development domains. Usually we follow the Denver development scoring chart scoring test, in which we have 5 major domains. We will discuss in this, in which we have motor. In motor we have gross motor, we have fine motor, we have a speech component, we have a social component, and we have a visual component. So we will discuss laterally in the lecture. So the main purpose here is to how to assess a child, development assessment. Okay, milestone is the acquisition of the key skill. Medium age is defined when the half of the population acquired this skill, and the limit age at which the skill should have been achieved is less than 2 standard deviations. So there are different terminology you will come across. In neurology and in this lecture also. One is the development delay. I already said it is usually delay with less than 2 standard deviation from the normal. How to calculate? Something will be discussed in subsequent slides. Global development delay is defined when, as I already have told you, that there are 5 domains of development. If more than 2 or more domains are affected, we label them as a global development delay. Development deviance is when the child develops milestone or skill outside a typical acquisition of sequence. Development dissociation, when the child has a widely differing rate of development in different domains of development. Suppose the patient is able to walk, but he is unable to speak. So this is an development dissociation. The last terminology is the development regression. Regression means backward. It means that once the child or person has acquired a skill and then he is losing it. Suppose the child is able to walk, talk, but sudden due to any insult like infection, tumor, his brain is affected, but now he is unable to walk, he is unable to speak. So this is development regression. So if you have any questions, you can always write and I will try to answer it out. So when it is important to do a development assessment, as far as the parents are concerned, if in the history there is a previous history of miscarriage or stillbirth, or any child proven to be mentally or physically handicapped, these are really worried parents. Whenever the child is born, they inquire doctor and ask repeatedly, is there any problem in my child? Is there any problem in my child? Because in the last child, I had this problem. I've lost my child last time. So for parents, it will have a difficult time, and it is also important and it is also difficult to convince them. If there is any antenatal problem or difficulty in delivery, like trauma, antenatal problem like the mother had fit, the mother had any infection, the mother had any accident, that can lead to trauma to the placenta or to placenta or to the fetus. So in that cases, it is more important for the development assessment. Family history of mental or submental normality, cerebral palsy or handicap. If not in the family, in the outside of family, his brothers and sisters' families, or any family near or far have any handicap, so they will be concerned and they will ask you, is there any problem in my child also? So one should know, the purpose of this thing all is that one should know how to assess development. It is not very difficult. It's a very easy talk. It's very easy. If you do a development assessment in 20 children or for 10 children, and if 20 children, you will be master. You will not be, if you do practice for 20 children, I think so you will be able, whenever you will see the child, you will be able to recognize that what is the age of the child by seeing the activity. Then you can ask, once you assess that this child is 2 years or 3 years or 6 months or 9 months, then you can ask the parents, oh, your child is lying on this age. Then you will assess, oh, this is a 2 year. Suppose that this is a 2 years old child and patient is unable to walk. So that will cause problem. That will cause many questions in your mind. What's the problem? Then you will go into the detailed history of antenatal, prenatal, any insult, any infection and all these things. So there are many risk factors. Suppose a patient comes to the child to the doctor, any pediatrician or to doctor. If he sees the child, the patient has poor sucking and swallowing, it means the primitive reflexes are not mature. So there is a problem. You will see, is there any problem went wrong during delivery, antenatally? Or you like to acquire about the family history then? If you see a child who is doing some unusual thing, if a 10 years old child, you ask to sit, he does not sit, he does not comply what you are saying, there is a matter of concern. If the 5 years old, 3 to 5 years old child making noise unnecessarily, so the pediatrician will say that there is some problem. You have to evaluate for this. One should also diagnose with this development. You will able to diagnose a defect of hearing and vision. You have to also see to those patients who are having metabolic disorders or who are given some medication like anticonvulsants or any CNS drug that causes change in the behavior. So you have to evaluate for all those things. So I was talking about the different domains. So there are 5 different domains. One is the gross motor, other is the fine motor, third is the social, cognitive, and intellectual development. The fourth is the speech and language development, and vision and hearing development. So these are the parameters. Lastly, in the slide, I was talking about the global development delay, which was defined as if more than 2 of these domains are affected, we label as a global development delay. So development milestones serve as the basis of most standardized assessment and screening tool. Whenever you do the development assessment, 2 separate development assessment over time are more predictive than a single one. Developmental not only should be aimed at identifying the child who has low function, but at directing the focus of anticipatory guidance to help promote normal development. Suppose the patient is unable to walk, unable to speak at the age of 15 months. Then you have to give him different tools for the stimulation to speak. Okay. Okay, when to suspect abnormalities development? From the parents' history, usually. You have to go for the examination, routine examination, and you have to go for the CNS examination. And you have to follow the high-risk babies. High-risk babies, you know who are the high-risk babies? Those usually who are low birth weight or had any complication during pregnancy and are being admitted to the nursery, or having any infection like meningitis. As you know that certain drugs, like especially when we talk about the neonatal age, the septic protocol says that give cephalosporin with aminoglycoside. So one have to check for the hearing. One have to always check for the hearing. in these patients. And of course, the disease by itself, like meningitis, encephalitis, or any CNS insult, can cause damage to the eighth nerve that can cause deafness. So there are risk factors for developmental impairment. As already said, use of drugs, alcohol, severe toxemia, and viral infection. In the perinatal factors, there can be low birth weight, prematurity, and other obstetrical complication. In the neonatal factors, neonatal encephalopathy, infection like sepsis, like meningitis, or having connectitis, which can be secondary to severe hyperbilirubinemia. In the postnatal, again, we have meningitis, encephalitis, exposure to toxins, severe continuous failure to thrive, and severe epilepsy. If there is severe epilepsy and if it's not controlled properly, there are chances that they will have some development impairment. Family history of hearing or visual loss can also lead to, is also a risk factor. That should be evaluated. So first we have to take the history for every, especially in medicine, either it is adult medicine or it is speech medicine, or also in the surgery also. History has its importance. One should take a very good history. Okay, most of the time you make your diagnosis on history basis only, and you can make it with more experience. Sometime, okay, as far as the development history is concerned in the development assessment, so that can have many factors. Like if sometimes the parent give the history that there is some problem in the child, but there is no problem. And sometimes there's a problem in the child, like if the patient is unable to sit at proper time, but the parents do not recognize. In that case, you have to counsel them gently. So there are different specific age-specific quotients that should be assessed, like walking, talking, relations. Check doubtful reply with quotient kept on a different ways. Suppose the parents are suffering from severe mental or psychiatric problem, and they are unable to take care of the child. So whenever you ask questions, they will give a very different way. So you have to be very alert. And whenever, and plus, if the parent says that milestones are developed at certain age, you have to go for examination to see it. Are they correct or not? It is important. The case is important when the affected first and second degree relatives are effective. You have to also take the social history. Okay, if the patient is mentally retarded, are the parents have the capacity to cope with the child disability? Suppose he is unable to walk. Will be able to get a wheelchair. This is also responsibility of the doctor, so that he can talk and he can only convey many social people to get help of it. Because doctors saying is really what it is certified that now this child wants this thing. So there are many people they will help you. As compared family members ask for help, it will have less weightage than the doctor. So while assessing the development, you it should be kept in a place with toys with one or more both parents are there, but there should be no prompting or helping. There can be normal chair or you can be floor also. Child behavior and interaction with the parents during the history taking should be observed prior to physical examination. Normal functioning motor, vision, hearing should be assessed. Actually, before going to this assessment, the child should be in good temper. He should not be hungry, tired, unwell, had convulsion prior, under influence of sedation and anti-epileptic drugs. If you do not follow this prerequisite, you may have different result when you're assessing development. Equipments, not much is needed except you should have a picture card. You could have a colors, different colors, particular hammer, paper, all these things. In general physical examination, you have to first go for the general physical examination. In general physical examination, what you see? The first thing you see for any dysmorphism. First, then you go for the vitals. Your first assessment. If you see suppose if you see a child with Down syndrome, you will say that there is a depressed nasal bridge, hypotonia, round face, low set ears, and many features. So then you make a diagnosis. So these children, like in Down syndrome, then you will say that these children should be assessed. These are the high risk patients, and these should be assessed for development. You should also go for the height, weight, head circumference. Head circumference is important. Again, it may be normal. It can be microcephaly or it can be macrocephaly. So if you see a child with these things, or is having a child with midline defect or cardiac murmur, so whenever you see anything, one defect, you will also look for the other defects in the body. And neurological examination, it is very important. One should know how to do the neurological examination. This will be, unfortunately, because of this lockdown, you are third year students, so you are unable to go through the wards. But ultimately, when things will go better, you will know how to assess, how to do the neurological examination. But I will suggest that you can always see in the videos. Don't waste time. Go to videos and try to finish your clinical examination. Suppose you are sitting not in Pakistan, you are sitting in some developed country. There, you don't get patients. You do with dummies. You do with videos. You learn with videos. So we are very lucky people. So we had hospital. We do examine and we do repeated examination, and nobody stops us. So this gives a lesson that this is a paradise for learning. Civil hospital is paradise for learning. If once one want to learn. So this is a Denver chart. You can get from your YouTubes, or you can get from the net, Googles. This is a chart. You should all take it out from the Googles after this lecture. Make up prints, at least 20 prints, and whenever you see a child, you should know how to assess these things. So there are parameters, different parameters, as you can see here. You can see this personal and social. You can see this fine motor. You can see this language going this way. You can see gross motor. This is the way you see for the gross motor. That's okay. This is the month. This is low is the month. This is 1 year, 15 months. Okay. You can see this for 5 years. Okay. So there are different parameters. This is years, 6 months, 9 months again. Suppose you have to talk about the 2 years. So follow this. What things come here? You're able to see. So this is the range. You know, it may start from 18 months. Like this case, you can start this problem. This can start from 18 months. It is also normal. So these are the ranges. Okay. Like this start from the 3 years, and that can be achieved by the 3.5 years. So both are normal. Because sometimes something the child is required 3 years, and some has required 3.5 years or 3.25 years. Both are considered to be normal. So there are different range. Like walking can be achieved from 9 months to 18 months. And if it is more than 18 months, that is worry. It is not worry when it is not present at the age of 15 months. Although some children can walk till from the age of 10 months also. Okay. So now we come to the different parameters for different age. So first we will be looking for 2 months old child. Okay. The 2 months old child, what will be the social and emotional? They begin to smile at the people, can briefly calm himself, may bring hands to mouth and suck on hands, and tries to look at parents. In the language, they can have a gurgling sounds. They can turn the head towards the sound. And when they are being slept in a prone position, they may be able to raise their head and chest. In the cognition, they pay attention to the faces. They may follow things with eyes and recognize the people at distance. When you are distant, they can recognize you. When you come close, they don't recognize you because of the numbers. They begin to act bored if FTT doesn't change. Sometimes they get bored, so they get bored, and they will reflect you by crying or by getting fussy. If you take a bottle, if you don't give a milk, they may be bored. They make you cry. Can hold up and begins to push up, lying on tummy. Sometimes they make smoother movements with arms and legs. In the 4-month-old child, usually the smile is spontaneous, especially at the people, like to play with the people and might cry when playing stop. Copies some movement in facial expressions, like smiling or throwing. In the language, they begin to babble. Tam, tam. Babbles with expression and copy sound he hears. They may show different ways to show hunger, pain, or being tired baby on floor with the toys. It seems to be very difficult, but once you will go with this chart and do practically, then you will be easy. It will be easy to remember. You don't have to remember all the things. You have to just remember the broad things. Broadly. In a 4-month-old child, in the cognition, you will know that he is happy or sad. Response to affection. Everybody like to love. Reaches for toy with one hand. Uses eye and hands together, such as seeing a toy and searching for it. They may follow moving things with eye from side to side. Watches faces closely. Recognize similar people, familiar people and things at a distance. A 4-month-old child can hold head steadily, unsupported. They may push down legs when feet are on the hard surface. May be able to roll over from the tummy to back. Can hold a toy and shake it and swing at dangling toys. Bringing hands to mouth and the lying on stomach pushes up to elbow. Now come to the 6-month-old child. Knows familiar faces, begin to know if someone is stranger. Like to play with others, especially the parents, and respond to other people emotional and often seem happy. He also likes to see himself in the mirror. In the language communication, respond to sound that by making sounds. String vowel together when babbling. A, I, O, U. Make sound to show joy and displeasure. And begin to say consonant words also sometime. In cognition, look around at things nearby. Bring things to mouth. Show curiosity, about things and tries to get things that are out of reach and begin to pass things from one hand to another. This is a 6 months old child. In the moment, roll over in both directions from front to back and back to front. Begin to sit without support. When standing, support weight on legs and might bounce. Rock back and forth, sometimes crawling backward before moving forward. So this all can happen in a 6 months old child. Now come to the 9 months old child. So maybe 9 months old child, the socially and emotionally, he may be afraid of strangers. As I already told you, if the child is less than 7 months, he can go to every person without any resistance. But once it has achieved 6 to 7 months, they will show a stranger anxiety. But it also depends on how many family members are there. If they have a very big family members, they don't go into the stranger anxiety usually. But if the family members are small, like 2 to 4 or less than 5, so if the strangers comes to them, the child will have anxiety. Language communication, the 9 months old child, he understands what is no. Make a lot of different words, sounds like mama, 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 papa, papa. They usually copy sounds and gesture of the others. And they also point finger at the thing. In the cognition, the 9 months old child watches the path of something as it falls. Look for things he sees you hide. Play a peekaboo. Peekaboo means that you have placed something below the pillow. Then he will find out the things. What is that? He will put things in her mouth. 9 months old child. Move things smoothly from one hand to another. Pick up things like cereal between thumb and index finger. It is called rattle holding. They can hold the rattle between the thumb and the index finger at 9 months of age. 9 months old child can stand up, can get into sitting position, can sit without support. It also pulls on stand and may crawl. 1 year old child. He may be shy or nervous with a stranger, as already told you. They usually cry when mom and dad leave the home. As compared to your age, you are happy when parents are out. Has a favorite things and people, show fear in some situation, repeat sound or action to get attention, put out arms, legs to help with dressing, and play games like peekaboo and pet a cat. In the language, they respond to the simple spoken request. Uses simple gesture like shaking head or waving bye-bye, goodbye. Make sounds with changes in sounds, in tone, like a speech. Say mama, dada, oh, and small mama, pani, so they can speak. In the cognition, explore things in different ways, like shaking, tagging, and throwing. They find the hidden things easily. Usually goes to those things we should not be used. They will go to the switchboards. Look at the right picture where it is named. They can copy the gesture also. They can start correctly, for example, drinking from the cup. They may brush hairs also. Put things in a container. Takes things out of the container. Let things go without help. Books the index finger. Follow simple direction like pick up the toy. The movement get a sticky position without help. Pull up to stand. Walk holding on a furniture. May take few steps without holding on and may stand alone. This is a picture of a 1-year-old child. Now comes to the 18 months. Like to hand things to other as play, may have temper tantrum, may be afraid of strangers, may show affection to the familiar people, play simple or pretend such as feeding a doll, may clinch or create a new situation. Point to show others something interesting, explore alone with parents close by, and toddler eating you from the blue bowl. In the language, say several single words. Say or shakes head, no. Points to show someone what he wants. In the cognition, knows what ordinary things are for. Example, telephone, spoon, cup, brush. Point to get attention of others. Show interest in doll and stuffed animal by pretending to feed. Point to one body part. Can follow first step verbal command with any gesture. For example, sit when you say sit down. In the movement, they can walk alone, may walk up steps and run, pulls toys while walking, can help her dress herself, drink from a cup and eats with a spoon. This you all expect from an 18 months old child. Now come to the 2 years old child. Copies, especially adult and the older children, get excited with the other children, show more and more independence, play mainly beside other children but is beginning of include other children such as chess games. In the language and communication, points things or picture they are named, knows name of the familiar people and body part, can say sentence from 2 to 4. They can follow simple instruction like stop here, sit down, stand up, eat, give it. Repeat words overhead in conversation, points to thing a book, and 2 years old play with the big ball. They are able to Play with the big ball like football, football size ball. In the cognition, they can find the hidden, even if it is under 2 to 3 covers. Begin to sort shape, begins to sort shape and colors, complete sentence and rhythm in familiar books, play simple make-believe games, and make tower of 2 or more block. May use one hand more than the others. So this dominancy of the right-handed is achieved till the age of 2 years. As compared, if it comes below the age of 18 months, it is a red flag signs. It is not good. It shows if the dominancy occurs below the age of 18 months, it means there is some problem, there is some disease like hemiplegia that is affecting the one part of the body. They can name the item pictures such as cat, birds, dogs, elephant. They can pick your shoes and put them in the closet. The moment stand on tiptoe, kick ball, begins to run, 2 years, climb onto and down from the furniture without help, walk up and down stairs holding on, throw ball overhand, make or copy straight lines and circle. In a 3 years old child, socially it copies adult and friends, shows affection for friends without prompting, shows concern from trying friends, understand the ideas of mine and his or hers, shows wide range of emotions, separate easily from mama and dad, may get upset with major changes in the routine, dress and undress self, toddler hugging dolls. In the language, follow instruction with 2 to 3 steps. Can name most familiar things. Understand word like in, on, under. Say first name, age, and sex. Name the friends. Say I, me, we, you, and some plural words also. Cars, dogs. Talk well enough for strangers to understand most of the time. Carry the conversation of 2 to 3 sentences. This is what 3 years old child can do in speech. In cognition, can work with toy, with buttons, lever, moving part. Does puzzle with 3 to 4 pieces. Understand two means. Copy circle with pencil or crayons. Turn book pages one at a time, and they can build a tower of 6 blocks. Can screw on screw jar lid or turn door handle. In the movement and physical activity, they can climb well, run easily, they can ride a pedal, tricycle, walk up and down with one step, foot. The 4 years old child enjoy doing new things, play with mom and dad, if more creative with, with make believe play, would rather play with other children than by himself, cooperate with other children. In the language, they know the basic grammar such as he or she. They can sing sounds, say a poem from memory such as Wheel on the Bus. They can tell you the story, can say first and the last name, and can also throw the ball. In the cognition, name some colors and some numbers. Understand the idea of counting. 4-year-old child. Start to understand time and remember part of the story. They understand the ideas of same and different. Draw a person with two to four body parts. Can use scissor. Can start to copy some capital letter also. Start board and card games. In the moment, they can hop, stand on one foot up to 2 seconds. Catches, bounces ball most of the time. Pour cuts with supervision and mash on food. They really like to work in the kitchen, helping their moms by cutting the potatoes, by cutting the carrots and other items. And finally, the final 5 years old child, they want to please friends. They like friends. They likely to agree with the rules, like to sing, dance, and act. Show concern and sympathy for others. Although they are is also aware of gender also in this age, 5 years old. Show more independency or may visit a door next to the member, but with adult supervision. If sometimes damaging and sometimes very cooperative. And they can also play with the guitar. 5 years old child. Speaks very clearly. They can tell us simple stories. They can use the future tense like grandmama will be there. Say the name and address. In cognition, they can count 10 or more things. Can draw a person with at least 6 body parts. Can print some letter or numbers. Copies a triangle and get geometrically shapes. Knows about things used every day like money and foods. So 5 years old can recognize the money. So be aware of them. Money is also a very attractive tool for the children because they know that when it is given to any shopkeeper, they give you ice cream or they give you candies. In the moment they can stand on one foot for 10 seconds or longer, hop, may be able to skip, can do somersault, kalabazia, using fork and spoon and sometimes a table knife. Can use the toilet by their own, swings and climb. So as far as the gross motor is concerned in the newborns, it is barely able to lift the head as compared to the 6 months old child. Easily lift head, chest, upper abdomen and can bear weight on arms. You can see this. On the left side is the newborn in which there is a lagging of the head. Unable to hold the head. As compared to the 6 months old child, you can see the child is able to control the head. So this is development. This is age. It is not that the left side, which is newborn, is abnormal. It is normal, but at this age, it is normal. If the age is more than 4 months, if the child does not achieve the holding of neck, it comes into negative. It means there is some problem going in that child. Sitting, 2 months old needs assistance, and 6 months old can sit alone in a tripod position. And an 8 months old child can sit without support and engage in play. You can see this child. A 2 months old do need a support as compared to the 8 months old. He is very steadily sitting with no support. and is plain. Ambulation. 9 months old child do crawl. 1 year old stand independently from the crawl position, and 13 months old walk and toddle quickly. And a 15 months old child can walk, run. As you can see this. If the child is between 9 months to 12 months, he is able to stand, but it is with support. As compared to the child who is 13 months old child is able to stand, is able to walk without support. So this Denver development screening test is most widely used test for screening. As already said, that it has domains like motor, gross motor, fine motor, language. These domains are present as age knobs, just like physical growth curve. This is a chart which showing what skill can do. A 3.5 years old child can make a circle. A 4 years old child make a cross. A 4.5 year old child can go for rectangle, and 5 to 6 and triangle. As compared to the block test, 3.5 years old child can make a bridge. 4.5 years old child can make a gate, and 5 to 6 years can build a step. So these are the skills which they achieve at different ages. There is a terminology called development quotient. You will not go into the details, but many times you will come across with a report. This assessment is done by the psychologist, but you should know how to assess this report. In the last 4 lines, you see the interpretation. The normal maximum score is 100, and if it is more than 85, we consider as a normal. If it is between 71 to 84%, we label as mild to moderate delay, and if it is less than 70, it is severe delay. So we were talking about the development, how to assess. So there are some red flag signs. Red flag signs means that you should be concerned if these children do these things at this age. If the weight of the child is if the age of the child is between birth to 3 months, normally the rolling develop after the age of 4 months. But if it's achieved during the 3 months, just check for hypotonia. If there is a persisting fisting at the hand till the age of 3 months, the patient is unable to open the hands. Most of the time, the hands are closed. These also need a evaluate for the neuromotor dysfunction. And if the patient is not alert with the environment or any stimuli, any phase, any sound, then you have to evaluate for the sensory impairment. This is for the 3 months, first 3 months. If the patient comes with the age of 4 to 6 months, if patient has a poor head control, it means there's a problem. The child may be suffering from hypotonia or any other cause. Failure to reach the object by 5 months, evaluate for the motor, visual, and a cognition deficit. And if the patient is not smiling, you have to evaluate for the visual loss. You have to evaluate for the attachment problems, evaluate for the maternal major depression, and you should always consider child abuse or neglected child. That can lead to absence of the smile if the age is more than 3 months. The red flag sign from 6 to 12 months, there is a persistence of the primitive reflexes. As I've already told you that primitive reflexes usually subside till the age of 4 months. If they are still present, this shows there is a dysfunction in the brain. If there is an absent babbling sound by the age of 6 months, then you should evaluate for the hearing. As you know that if there is a problem in hearing, if there is deafness, automatically, if the patient does not listen anything, he will not be able to speak. So once the ears are damaged, the child will have very difficulty to speak because he's not listening what the world is saying. It is a absent strangers anxiety by the age of 7 months is also a red flag sign. But as I have already told you, it is related to the multiple care provider. Inability to localize the sound by 10 months or persistent or mouthing of object at 12 months may indicate lack of intellectual curiosity. Red flag signs of 12 to 14 months, lack of consonant production by 15 months. It means you have to go for the hearing, you have to evaluate for the hearing loss. Loss of imitation by the 16 months, evaluate for the hearing deficit and evaluate for the cognition and social deficit. Hand dominance prior to 18 months, as I already told you, they may indicate there is a contralateral weakness, maybe due to hemiparesis. And if the patient is unable to walk up and down stairs at the age of 12 months, may lack appropriate opportunity rather than motor deficits. Advanced non-communicable speech like echolalia is a red flag sign. Speak repeatedly. Simple command not understand suggests abnormality. Evaluate for autism. Evaluate for the pervasive development disorders. And delayed language development requires hearing loss. Evaluate in all the children who have language problem. One should always evaluate for hearing. So, infant who shows suspected early sign development delay need to provide opportunity that promote body control, acquisition of the motor skill development, and psychological maturity. Making additional effort to make the child sit or walk, give toys to manipulate. If you pick up the things early, because this is the age, you can help them, and these things can be made easier as compared if if the age goes on more than 5 years, then other problem starts. Sometimes if the patient is unable to stand, he may develop contractures. So once these patients are being cared for in early life, so this contraction and all will not happen. So making additional effort to make the child sit or walk, give toys to the manipulate, play with the child, show objects, speaking to the child and encouraging him to speak promptly, the child to interact with others. This is all for this. If you have any questions, you can write it down. I will try to clear your queries. Okay, any questions? Okay, thank you, students. Allah Hafiz.